Hello everyone, today we'll be talking about next part of lung mechanics, respiratory system resistance. So let's get started. In the previous lecture, we understood that non-elastic resistance comprises of frictional resistance to airflow, frictional resistance to the tissue deformation, and inertia of gas and tissues. The work done against non-elastic resistance is dissipated as heat. There are two types of flows, laminar and turbulent. The flow rate in laminar flow depends upon fourth power of radius and is directly proportional to pressure gradient, while in a turbulent flow, the flow rate is proportional only to square of radius and square root of pressure gradient. So for the same radius and pressure gradient, flow is much higher in laminar flow when compared to turbulent flow. In other words, turbulent flow has got higher resistance than a laminar flow. Reynolds number is the transition point between laminar and turbulent flow, and if this number is more than 2000 to 3000, the flow is turbulent. And Reynolds number is given by this formula. So Reynolds numbers depends upon gas density, mean flow, and airway diameter, and inversely proportional to gas viscosity. You'll be more prone to turbulent flow if Reynolds number is high. So it will be higher for small diameter, higher flow rates, and gas with high density to viscosity ratio. So you can see that heliox has got least density to viscosity ratio, so it reduces Reynolds numbers, hence it is used for asthma exacerbation. To reduce the resistance, there are only three principles. Make your airway diameter bigger, which is the most important, drop down the flow rates, and decrease the density to viscosity ratio of the gas. Another important thing to know is entrance length, which is the distance of the tube flow must occur before a laminar flow is established. And it is given by this formula. And this is important because heliox works in multiple ways. Apart from reducing the Reynolds number, it also quickly re-establishes the laminar flow because it reduces the entrance length. Because of its low density, it also decreases the resistance if turbulence is present. However, remember that most of the turbulence occurrence is in the upper airways, and asthma and COPD are much more distal disease, so their usefulness is limited to very severe asthma. Most of the airway resistance is in the initial generation of the bronchus. In fact, 80% of the resistance occurs till the 7th order bronchi. Look at the pressure drop, and higher the pressure drop, higher is the resistance. You can see that the pressure drop in the earlier airway generation is much higher than the later generations. Other thing to notice is the Reynolds number of various part of the airways, and you can see the Reynolds numbers looks less than 2000. However, the laminar flow doesn't occur till 11th order bronchi because the length of these tubes are much smaller than the entrance length. So if you look at the 11th order bronchi, that's where the actual length of the tube is longer than the entrance length, so laminar flow can occur. The airway generation after terminal bronchioles have hardly any resistance. To find total airway resistance, you combine the component from laminar flow and component from the turbulent flow. Since the driving pressure depends on flow in laminar flow and flow square in turbulent flow, you can write total driving pressure to be sum of these two. You can further simplify the formula to K multiplied by flow raised to power n. If n equals 1, that means the flow is laminar, and if n is equal to 2, that means flow is all turbulent, and any number between 1 and 2 would show you mix of various laminar and turbulent proportions. In humans, pressure gradient equals 0.24 multiplied by flow raised to power 1.3. Total resistance, however, is combination of total airway resistance, frictional resistance, and inertia of gas and tissues. And this is given by the Rohrer's equation, where you got all these three components. The important thing to understand about inertia of gas and tissues that it is frequency dependent, so it becomes important only when you are on high frequency oscillators. The airway resistance in upper airways is around 40% and smaller airways is around 7%. And similarly, the frictional resistance to tissue deformation is mostly in chest wall, which comprises of 46% of total resistance. Airway diameter is the only modality you can change to treat your obstructive lung diseases. So let's see how these things are controlled. Lung is supplied by the parasympathetic system, supplied by the vagus nerve, and this causes bronchoconstriction both by the muscarinic type 3 receptors, which are sensitive to acetylcholine, Stimulation of C fibers in the bronchial walls is also carried by the vagus nerve. There is an alternate system of vasoactive intestinal peptide, which is slower system but can cause smooth muscle contraction. Lungs do not have any sympathetic nerves and only respond to circulating catecholamines. They do have beta-2 receptors which cause bronchial muscle dilatation. You can have physical and chemical stimulants which cause bronchoconstriction, and you do have a lot of inflammatory mediators which can cause both bronchoconstriction or bronchodilation. And if you look at this table, you can see that there are multiple prostaglandins, leukotrienes, which can cause bronchoconstriction or bronchodilation and are the target for treatment in various diseases such as asthma and COPD. There are a couple of things that you have to understand in resistance. First of them is volume-related airway collapse. So at functional residual capacity, your intrapleural pressure is negative. However, if you start exhaling forcefully, you can exhale till your residual volume. And since your pressure inside the lungs are positive and the lungs are smaller, you will see that the airways get narrow and your resistance increases. However, if you take a deep inhalation and move toward total lung capacity, the resistance drops. So remember that airway resistance increases with decreasing lung volumes. This gives to a term called closing capacity. As you continue your exhalation beyond FRC, your airway starts getting narrowed and a point comes where some of the airway starts collapsing. And as you move towards residual volume, the airways can collapse entirely. The volume of air at which the airway closure begins is called closing capacity. And this is important because closing capacity increases with age. Beyond 75 years, you can see that your closing capacity is higher than your FRC. So that means that your alveoli are closing during your normal tidal respiration. And this is one of the reasons that your PaO2 decreases with age, because the areas which are now collapsed are acting as a shunt, therefore decreasing your PaO2. At low lung volumes, the flow becomes independent of effort, and that happens because as you increase your intrapleural pressures, your pressure gradient increases, however the diameter drops. And as you know, the flow rate depends more on the diameter of the airway rather than on pressure gradient. So you would not be able to overcome the reduction in flow rate generated by smaller diameter of the airway. Second principle to understand is flow-related airway collapse. Flow is highest in the upper airways because their overall diameter is the narrowest, and therefore because of Bernoulli's principle, you can have very high transmural pressures. That's why you have got cartilaginous rings in the upper airways till 11th generation to prevent these collapses. However, you can see these airway collapse in patients with bronchotracheomalacia and excessive aerodynamic collapse because posterior wall of trachea does not have cartilage. This can be overcome by giving simple things like CPAP, which is a positive pressure inside the trachea, to overcome these transmural pressures. So if you remember Bernoulli's principle, if you have got narrower airways, you got higher velocity, and therefore you have more pressure gradient across that tube now. And this would depend upon the square of initial velocity and square of ratio of cross-sectional area. Therefore, narrower airways have tendency to collapse even further. This in fact collapses the airway further, and obstruction leads to more obstruction. So one of the things that you must have noticed is reducing anxiety of the patient or making them breathe slowly and comfortably, if they can, helps reduce the obstruction and decrease work of breathing. Dexmedetomidine is a very useful drug which can reduce anxiety but not reduce your respiratory drive. So you can use this in a patient with COPD or asthma exacerbation. One of the things that you will notice that because of the negative intrapleural pressure during inspiration, the airways are more stretched and have lower resistance as compared to expiration. However, in forced expiration, the intrapleural pressure are more positive and they can narrow the airways further, thus increasing the resistance and causing air trapping. This is called dynamic airway compression. This is unfortunately very common in COPD exacerbation, where the patient cannot breathe out, so they are trying to generate more and more intrathoracic pressure to exhale, and this unfortunately works against them, so they go down and downward spiral. The intrapleural pressures are not only felt by the alveoli, but they're also felt by the intrathoracic airways as well. So there are few things that you need to notice. There's a pressure drop through the bronchi as you move from alveoli to the outside air. There are supporting structure and supporting cartilage that prevents the collapse of the airways. However, if you perform a forced expiration, the extra pressure thus generated in the pleura is going to compress the airways and increase the obstruction. So your expiration is going to become more challenging as you increase the intrathoracic pressure. Remember that the flow was independent of effort because of this underlying reason. In COPD, this can happen much earlier because COPD patients have destruction of cartilage and supporting structure. There is more resistance, therefore causes more rapid air pressure drop, and increased flow through the narrow passes causes more transmural pressure difference. So COPD patients are very prone to airway collapse. Unfortunately, as their breathing gets worse, they generate more intrathoracic pressure, and this makes their airflow even worse. Most patients with COPD exacerbation undergo a downward spiral where their intrathoracic pressure keeps on increasing and more resistance is building up in the system. Using modalities like CPAP increases your pressure inside the airways and opens up the collapsed airways. To measure resistance, perform an inspiratory pause. Once you perform an inspiratory pause, the pressure is slowly going to come down and reach an equilibrium, which is called plateau pressure. A point will come where the flow on the ventilator will drop down to 0, and this point is called P1. You'll notice that the plateau pressure is slightly lower than the point P1, and this is because the drop from the peak to the P1 shows air resistance as the flow has stopped, while drop from P1 to P2 is occurring because there is still some air movement that is being exchanged among the alveoli because the alveoli can have different time constant. There's also viscoelastic property of the lungs and chest wall which need some time for stress relaxation. The total resistance is sum of these two resistance. So if you're looking at airway resistance, you subtract P1 from peak and divide it by flow rate. And to get tissue resistance, you find the difference between P1 and P2 and divide them by flow rate. To get total resistance, it's your peak minus plateau divided by flow rate. You can also look at the flow volume loop to figure out if there is an obstructive component. You will see this scooped out appearance on a flow volume loop when you are dealing with patients with COPD or asthma or any obstructive disease. You can also look at your inspiratory loop, and if you see any flattening, that suggests variable extrathoracic obstruction. If you see flattening of the expiratory loop, that means you have got some variable intrathoracic obstruction. Flattening of both expiratory and inspiratory loop are suggestive of fixed upper way obstruction like tracheal stenosis. In summary, the resistance of airway comes from airway resistance, frictional resistance to tissue deformation, and inertia of gas in tissues. The airway resistance can be manipulated by changing the airway diameter, and you can use bronchodilators. You breathe at higher lung volumes, decrease the flow rates, add positive pressure to the airways, and you can use gas with lower density or viscosity. Airway resistance can be measured by performing an inspiratory pause and then subtracting the plateau pressure from the peak pressure and dividing by the flow rates. You can also get some idea of airway resistance by observing flow volume loops. Thank you.